better, obviously, than some states in the country. Overall preterm birth rate in Tennessee, 10.8%. Look at some of the different cities, and I know you all, a lot of you all maybe live right here in Chattanooga, and I'm sorry I had to put a frowny face beside Chattanooga. Memphis is the worst. I think those of us that have lived in Tennessee for a long time know that the health statistics in Memphis are generally worse than some other parts of the state. That's not in every situation, but definitely some. And I know some people have joked that if we could carve Memphis off and just let them be in another state, our overall statistics in terms of neonatal mortality and some other things would look better. No offense to you all from Memphis, y'all are great. But you all know what you face in terms of some disparities in health. So Clarksville, anybody from Clarksville here today? They're doing quite well. So good for you in Clarksville. I don't know what you're doing better than the rest of us. But I think that what it gets down to is that all of these cities that you see listed here have tertiary medical centers that provide quality care. So it's not the issue of not being able to provide good care. It's probably the issue of the health of the population that you're serving. And we know that that's a big deal with preterm birth. So some trends, at least, this is again Tennessee, and you can see the bar graph, 2001 to the far left, and then over to 2015. We're doing better, and that's encouraging, that at least we're seeing the numbers go down in the last several years versus go up. So at least we're kind of moving in that right direction. Although, and as this was mentioned earlier today, most of the gains we have made in decreasing the numbers of preterm births have been in late preterm births, and we're not seeing very much change right now in the very, very early preterm birth rates. So that's something that we still hopefully can improve upon. Healthcare cost to employers, I just thought this was an interesting statistic. This also came from the Institute of Medicine on preterm birth that was published in a March of Dimes publication as well. Notice the difference in cost to an employer. Employers that are providing health plans to their employees, and we know that that's a big issue in our country right now with, which employers and what size companies are providing employee benefits. So employers obviously are interested in having a healthy employee, right? And it benefits them when they don't have to spend as much on your medical care. So a full-term birth with no complications cost to the employer about $4,500. With the diagnosis of prematurity, $49,000. So that's something that I think employers are also taking a look at, not just in terms of pregnancy issues, but all over healthcare spending. What are the places that we could save money? What can we do to improve the health of our employees that can end up saving us money? And then the annual societal economic burden of premature birth in our country is estimated to be over $26 billion. That's a lot of money, and I think that obviously we're not rolling in money here in the United States of America right now. Look at our deficit that we have in our government. So money is definitely something people are going to pay attention to, and if we can come up with things that save money, that's good. Obviously, we're also interested in health, and we're interested in these children having a better life, and prematurity definitely is a problem for that. So etiology of preterm birth, I think we don't know everything, but may sound kind of like a silly statistic, but 70% of preterm births result from preterm labor or preterm rupture of membranes. That means about 30% of preterm births are probably a result of our intervention. So we know that we have to deliver patients early based on risk to the fetus or risk to the mother. So preeclampsia, growth-restricted babies, certain fetal anomalies. There are different reasons why we choose to deliver early, feeling that the outcome is better for that baby at that point. But the vast majority result from preterm labor and preterm rupture. So of those babies, of those births, what are the mechanisms? And these have been talked about already today, and I don't want to spend time on them, but those four major pathways that most likely lead to preterm labor and therefore to preterm birth would be stress, and that can be the stress, psychological stress in the mother, emotional stress, but also physiologic stress. So we know that when the fetus, when the placenta is not functioning well based on maybe destined to become preeclamptic pregnancy or a gestational hypertensive pregnancy, that when that placenta isn't functioning well, that causes stress to that fetus, and that fetus That's life form. Okay. Oh, we're missing it. I'm sorry. I should let y'all run outside and run back in and see the helicopter land. But that stress makes the fetus produce stress hormones as well. And so that's going to lead to preterm birth. Infection, inflammatory response is another mechanism. Bleeding, hemorrhage, so even a marginal sinus abruption that a patient has might place them at higher risk for going into preterm labor than someone that doesn't ever have any decidual interruption. And then uterine distension, so your multiple pregnancy, your polyhydramnios. So when that muscle is overstretched, it really activates the myosin light chain kinase to make that actin and myosin filaments contract. So those are all things I think that we're fairly familiar with. Risk factors as well, I'm not going to go through these with you. Other speakers have talked about these today and touched on them. You see them in different sets of slides. But I do think it's something to pay attention to. Obviously, there's women that go into preterm labor that don't have these risk factors. So we can't just take a good history and automatically know who we're going to end up seeing later on at 28 weeks with preterm labor. It's not all about history taking. But I think it is something that we have to pay attention to. So hopefully your patients that are getting prenatal care are getting a good, solid OB history. We need to know what happened in their previous pregnancies that may impact, but we know that doesn't always 100% tell us the story of what we can do. So assessment, uterine contractions that produce cervical change at less than 37 weeks, kind of that standard definition for preterm labor. We've heard a lot today already about fetal fibronectin and about cervical length measurements, so I'm not going to continue to go through those with you. But I do want to point out from a nursing perspective, please, please, please be very careful to think about what your policy is at your hospital about obtaining a fetal fibronectin. And some of you all, I imagine in a group this size, some of you all work at night in the hospital, okay? And so you may have a patient coming in, showing up in your unit that you're triaging, and you may not have a physician available at that moment to come in and see that patient. You may have to call them in from home. And so in the meantime, there may be things that you have in place that you go ahead and do assessment-wise. And getting that fetal fibronectin first is very, very important. Go ahead and get it, unless you have some policy that doesn't have you doing that. But getting it is not a big deal. You get the swab, you have it, you can always toss it in the trash can. But if you have put a speculum in her, if you have done a digital exam, you can't get that test. So just think about that. Again, educate your younger nurses. A lot of times those are your ones that are working at night. So educate them about the policy, the plan to get that fibronectin. Okay, so interestingly enough, we know that not doing anything at all doesn't mean that everybody delivers preterm, right? People can come in contracting and they can have some cervical change. If we did nothing at all, a lot of them would still deliver at term. So deciding who to treat is very difficult, and that's something that we know we overtreat. We know that we give women tocolytic medication and steroids, and they come back and have to be induced at 41 weeks. So we know that happens, but it's very difficult when you don't really know what is a normal cervix for somebody at 28 weeks. What is a normal cervix at 30 weeks? It's not the same thing for every single person. And so we have to just go with judgment call, we have to go with evidence-based medicine, and we sometimes treat when we don't need to. But I thought this was kind of interesting looking at this meta-analysis of studies between 1950 and 2011. So we're covering a lot of years. I have not actually been practicing through all of this time, but it feels like it sometimes. So looking at this over 1,300 women, you can see, again, not treated at all, 40% delivered at term. 67.2% mean were undelivered within 2 days, and even, so forth. So quite a large number of these patients didn't deliver preterm or didn't deliver quickly, even when they didn't have any treatment. So this is a little bit more recent study that came out in the Gray Journal in 2013, looking at the cost of unnecessary admissions and treatments. Okay, y'all can probably see the slides a little bit better. Thank you. That's okay. So look at this particular study. 139 patients admitted and treated for preterm labor. Over 30% had a cervical length more than 3 centimeters. None of those patients delivered preterm. None of them. Of the ones that had a normal cervical length, none of them delivered preterm. but they had been treated in the hospital for preterm labor because they came in contracting. Total hospital charges in that group, over $1 million. That's a lot of money. So I really enjoyed listening to the talk, talking about cervical length measurement, and listening to them say that even though it's not a standard of care right now in this country to do cervical length measurements on every patient, they would do them. They would do cervical length measurements as part of their routine antepartum care, and I think that there's obviously some reason to think that's a good idea. Okay, so let's go on and talk a little bit about the different tocolytic agents that are out there that we are currently using in practice, and kind of some risk and benefits and some nursing implications with that. First of all, before you would start a tocolytic on a patient, you want to make sure that there's not any contraindications. And there are some specific contraindications for certain meds, but in general, these patients that I'm listed up here would be ones that we would not want to tocalize. Okay, so obviously, when there's no benefit to the baby to stay inside the mother anymore, we don't want to keep her pregnant. If the mother has a condition like preeclampsia, an illness that makes she would do better not pregnant, we don't want to keep her pregnant. So you do want to kind of think about that. You can see that where I put preterm premature rupture of membranes with a little star. We generally don't tocalize women who have ruptured membranes because we know that infection plays a big role in that process. And if we tocalize her, then we could mask labor that could be her body's natural way of ending that pregnancy. However, current recommendations for using magnesium sulfate for neuroprotection of the fetus would include the premature ruptured patients. So we would still, a lot of patients with ruptured membranes are going to get 12 hours of mag sulfate because of the neuroprotective effect to that fetus. We also know that there is great benefit in getting women to a tertiary care center before they deliver a preterm baby. So for those of you that are in outlying areas that know that your patient may have a fairly lengthy amount of time before she can get to that tertiary center, keeping her on a tocolytic agent to keep her uterus quiet for transport can also be of great benefit. We would much rather, even if she delivers the next day, we would rather that 26-weeker deliver at the higher level NICU than deliver, in a level 1 facility that's not really geared for that. So there are reasons to use tocolytics with patients that are ruptured, but in general, it's not the same use as it would be for somebody that has intact membranes. So optimal candidates would be in earlier phases of preterm labor. ACOG practice bulletin says that you should use interventions if the likelihood of delivering is delay of delivery would be a benefit to that fetus, so number one. And then generally we know that tocolytic therapy you can count on it being effective for about 48 hours, and that's just kind of an overall general rule of thumb. Now, is that beneficial then to delay delivery for 2 days? Absolutely it is, if you can get steroids on board. And that's really our main goal, is getting these patients steroid complete. Anything else that we do past that is what I think of as the whipped cream on top of the hot fudge on top of the sundae. It's not necessary, or it's not absolutely guaranteed, but it's very, very nice to have, if anything we can get. So a meta-analysis of randomized trials, again looking at lots of different agents, and we're going to talk about some specifically. They did find that in general, the tocolytic agents that we have available for use are more effective than placebos for delaying delivery for 48 hours and even for 7 days. So usually you hear that term used, generally effective for about 2 to 7 days, that you can buy that much time. Now again, not only is that beneficial for getting steroids on board for these patients, but when you talk about survival rates at delivery at 24 weeks and 0 days versus 25 weeks and 0 days, 26 weeks and 0 days, buying 7 days in that time frame is really improving your baby's chance for not only just pure survival, but also intact survival. So the morbidity rates typically drop. Fresh from the January ACOG bulletin. So if you haven't seen this bulletin yet, they put out a new bulletin on preterm labor management and really just changed a little bit of wording. So ACOG and the SMFM, Society for Maternal Fetal Medicine, recommend not administering tocolysis before 24 weeks, but consider its use at 23 weeks based on individual circumstances. So that's kind of the new thing out, is that we're going to start looking at considering tocolysis and considering steroids in that 23 to 24 week population. And you may have already found physicians that you work with that were doing that, but this is what's come out of ACOG just last month. So that's kind of newer to consider. And I think it just has to do with the fact that we keep backing up that age of viability, and we're starting to see some survival at 23 to 24 weeks that we really weren't seeing years ago. Okay, so what are the different agents that we have? And those of you that have been working in OB for a long time are going to be really familiar with all of these medications because there's nothing new out there. We've not discovered some brand new wonder tocolytic drug that we didn't have 5 years ago. Everything is basically the same, although some of the recommendations, some of the warnings, et cetera, have changed in the last few years. So beta-adrenergic agents, this would be terbutaline or Brethine. Those of you that are as old as me would remember using Ritodrine. Ritodrine being the only FDA-approved drug at the time, but it's not on the market anymore. So we do have terbutaline. It's been around for a while. Terbutaline at one point was given IV. It was given as a continuous tocolytic medication, sometimes for a fairly long period of time. It also was the drug that was the sub-Q medication back when women were having home uterine monitoring, and we had lots of women on terbutaline pumps. So some of you have a memory of terbutaline being not only a very popular drug and a very widely used drug, but also one that was used long-term. And that's really where we've seen the difference come in more recent years. So side effects of terbutaline. We know that it causes maternal and fetal tachycardia. Its main action is on beta-2 receptors in the uterine smooth muscle to keep that smooth muscle relaxed by keeping calcium out of the cell, but it also has action on beta-1 receptors in cardiac muscle. So that's why we see tachycardia, okay? Hypotension is another side effect, so you want to consider your patient's blood pressure and think of that as a not complete contraindication to giving it, but definitely a relative contraindication. Also can cause shortness of breath, palpitations, hypokalemia, and hyperglycemia. So another relative contraindication to using this drug would be in your diabetic patients because we don't want to increase their blood sugar even more than we already are trying to work to keep it down. Fetal side effects would be tachycardia, same as you see with the mom. And then if the mother gets hyperglycemic, you might see a rebound hypoglycemia. So again, something to think about when you're doing that great report to your nursery people. If somebody has had terbutaline on board right before they deliver, potentially that baby might have a little bit of a blood sugar problem. Not that common. So the FDA, I can't remember if I put this on here. Yeah, I think I did. So the FDA has warned that injectable terbutaline should not be used beyond 48 to 72 hours, okay? Oral terbutaline should not be used at all because it's not really shown to be very effective. So I think that's kind of an important thing for you to remember. And one other thing that I think is really important about paying attention to what's come out in the literature, whether it's an ACOG bulletin, whether it's an FDA warning, et cetera, is to really, really know what it says, okay? Where do your patients today get a lot of their, what they consider knowledge about healthcare? Where do they find that from? Facebook. Okay, I'm hearing Facebook, I'm hearing internet, obviously some form, they get social media and Google, okay? 30 years ago, where did your patients get most of their healthcare information? Their doctor and their nurse, right? Maybe their grandmother and their neighbor, et cetera. But really, they were learning it from healthcare professionals who were teaching them what they needed to know about their condition. Now they're coming in armed with all sorts of information, which may or may not be accurate, as you know. Okay, let me give you just an example to consider. Not that you would fall for this, but your patients might, okay? You don't have to raise your hand, But does anybody in the audience enjoy champagne? Okay, and I'll raise my hand because I do. Okay, so there was a study that came out not too long ago that said drinking 3 glasses of champagne a day would help ward off dementia. It was great for your health. So I'm like, wow, 3 a day? I don't really know if I could fit that in certainly on a full work day. It'd be hard to fit in 3 glasses of champagne. But wow, that sounds great. Okay. Well, not very long after that, there was a rebuttal, and it said, actually, it's 3 glasses a week. Okay. And actually, the study was done on rats, not on humans. So again, you have to kind of consider and think about when you hear a study has been published that shows really what was being studied. You know, kind of the same thing if somebody said, I just did a study and 100% of the people in the study loved chocolate. So then you say, everybody in the world loves chocolate. Oh my gosh, everybody in the whole world. Well, the study was done on 3 people. Okay, so you have to think about this research. Now, I think that we all, as healthcare people, read research more critically and evaluate it more carefully. But think about the patients that you take care of. So you may have a patient, and she may come in contracting, and her cervix has changed from closed to fingertip and 50%, and she's contracting and she feels them, and the decision is made to give her 0.25 sub-Q of terbutaline. And you walk in the room and you say, this is what we're giving you, and explain what the drug does. And she goes, there's an FDA warning about terbutaline. It is not safe. You need to be able to say, I am very aware of that FDA warning. It was published in, I'm going to say a couple years ago, I should know that. You need to understand that it is talking about using this drug over a 48 to 72 hour period, not a one-time low dose. And of course, you're going to say it real therapeutically and sweetly. But that's the important piece here that I want you to take home, is that your patients are going to come say all sorts of things that they've read. You need to know more, and you need to know the right information. Monitoring, main thing here, obviously we would consider holding this drug if the mom's heart rate is greater than 120 beats per minute. If she is hemorrhaging, you would likely consider holding this medication as well. Again, it's going to be risk-benefit and what the physician thinks would benefit the patient the most. I don't think any of us are using this drug as a continuous IV medication anymore, but if you were, then you would probably want to add in some glucose monitoring specifically. Okay, COX inhibitors. This would be probably the most common one you're using in practice would be Procardia, nifedipine. I'm sorry, I'm in the wrong set of drugs. This is your indomethacin, sorry. Y'all are going like, wait a minute, I think she's wrong. Okay, so indomethacin, these are drugs that are basically in the same category as your non-steroidal anti-inflammatory agents. Indomethacin basically keeps prostaglandins from forming. Okay, so that's the short answer. And we know that prostaglandin formation is going to increase contractions. It also helps to break down the cervix, makes the cervix softer, more likely to open. So prostaglandin release is great late in pregnancy when it's time for the body to go into labor, not great early. So that's why we want to prevent. Indomethacin, I would say what you're seeing in the literature these days, it's probably the most effective tocolytic that we have. Okay, it works quite well. Very few effects for the mom. You see some things listed there, but if they are allowed to eat when they're taking this medication, they typically don't have the GI side effects that you see. Okay, we know that any of these drugs in this class can interfere with platelet activity, so you want to be aware of that. If they've been taking it for a few days and then go into labor and deliver, you might have a little heightened awareness for hemorrhage, but typically that's not something that we see as a problem. The real problem with this medication, and while we can't give it all the time to everybody, is the effects that it has on the fetus. And so indomethacin, indocin, can and does cause premature closure of the ductus arteriosus. That is the communication in your fetal circulation pattern that is between the pulmonary artery and the descending aorta. And so if we close that down, you're really interfering greatly with that baby's circulation pattern. This drug is more likely to cause that to happen later in gestation versus earlier, and it is also more likely to occur with more continued use. So the recommendations for using this drug would be that you don't use it at greater than 32 completed weeks of gestation, use it in the earlier pregnancy, and it's not given for more than 48 hours. So that's kind of important things to know about that. I remember back in the day when we weren't really sure how long we could give it and all that kind of stuff, and they would actually do echoes on the baby's hearts and look for regurgitation around the tricuspid valve, and that would tell them if they had that regurgitation in that valve, would tell them that that ductus was narrowing, and then they would stop the drug. The nice thing is, if you discontinue the medication, the problem will reverse and we'll go back to opening up again. So it's not a permanent thing, but we've really just kind of nixed that possibility by doing short-term use and doing it at less than 32 weeks. So really safe from that perspective. So here are just some basic contraindications: platelet dysfunction, active bleeding. If they have asthma with a hypersensitivity to aspirin, they say that they shouldn't get it. And really, there's not anything really from a nursing perspective that you have to be super aware of. You're not going to be doing an ultrasound to evaluate for oligo or for narrowing of a ductus arteriosus. You need to tell your patients about that if they've asked. They may have read that on the internet too. I don't want to take my Indocin because I heard it messes up my baby's heart. I read it. I Googled it. You need to be able to tell them, this is why we're giving you this dose. We're planning to give you this drug for 24 hours. We're not giving it to you long term. You're 25 weeks. That problem happens a lot more if later gestation. Educate them and be the one that's really knowledgeable, okay? All right, calcium channel blockers. So again, the one that you're probably most likely to give your patient is Procardia or nifedipine. That's the one that's been studied the most in terms of OB with preterm labor. It does block the influx of calcium into the cell. We know that intracellular calcium is a precursor for uterine or muscle contraction in uterine muscle. Side effects of the calcium channel blockers, we know that these are also given as antihypertensive meds, and so they do cause some vasodilation. Some patients don't tolerate them real well, flushing, headache, that type of thing. Some patients tolerate it very, very nicely and don't have really any noticeable side effects. So it's a little bit patient dependent. Really no significant effects for the fetus, so that's a nice thing that we know that we're not really doing anything that potentially could harm the baby at all. And they work okay, kind of like everything else. They probably work okay. I felt like we started using these a fair amount, or where they kind of got noticed more was in our diabetic population. And this was back in the day when we were sending people home on oral terbutaline to stay on that for a long period of time. We didn't want to do that with those diabetics, so we were using Procardia, and that's kind of when we started to say, oh, you know, it works pretty well too. I kind of see it not as popular today as it might have been. You know, every drug has its day. I'm not seeing a lot of Procardia used, but some places may use it a lot more than we do. So you can think about your own. Nothing real big here, just a few kind of relative contraindications, mostly things that you don't really probably have very few patients that have left ventricular dysfunction or congestive heart failure. Most of our OB patients don't have situations like that. Okay, so now magnesium sulfate. How many of you all feel like that magnesium sulfate is your frontline tocolytic in your labor and delivery unit? Okay, not that many. Interesting. Some. Okay, maybe a few more. Okay, so this is a drug that's been around for a very, very long time, IV medication. It is also used to treat preeclampsia. So we have two major high-risk conditions in pregnancy that we use the exact same medication for in the same dose and in the same way, basically. Okay, so it's a drug that I think labor and delivery nurses are very familiar with, but I think it's very important that you understand some subtle differences between giving it to your preeclamptic patient and giving it to your preterm labor patient. Okay, so it does compete with calcium. It's a drug that we don't actually really fully understand how it works, but magnesium does have a 2+ ion charge, as does calcium, so it likely competes with calcium getting into the cell. So this is a drug that's classified as a neuromuscular sedative. So it really just relaxes all of the muscles in the body. So it not only relaxes the uterus, but it relaxes everything else they have too. And so you know these patients, and they are lethargic. They're hot because this drug has a vasodilating effect, so they tend to be hot and flushed. They can get headaches from it. So those are kind of the more common things that we see. The things that you worry about, not that we enjoy our patients being hot and uncomfortable, we don't like them to be uncomfortable, but those are not toxic effects. What we worry about are the toxic effects, and you need to think about the fact that magnesium is a dose, it's dose dependent in terms of toxicity, and it is a drug that is excreted by the kidneys, and so if your patient is making adequate urine, you should not be seeing toxic effects. So what are the important things nursing-wise that we want to do for these patients, okay? We want to monitor their urine output very, very carefully. If this patient is preeclamptic, and I know we're not talking about that today, but just to think about the differences, those patients are very likely to have renal involvement with their disease and not make a lot of urine. They need a Foley catheter in. With a urometer, you can do accurate hourly measurements. Preterm labor, I think you don't have to have a Foley catheter in these patients. You can, you may, for whatever reason, you may want one. But if they can get on a bedpan, if they can adequately, show you every few hours that there's output there and you can measure it and it's adequate, then you're probably okay. But that's the important thing. If they are making urine, they are putting out magnesium as fast as you are pumping it in. Okay, that's very important. Other things to watch for: reflexes. Deep tendon reflexes will tend to be one of the first things to diminish when a patient is getting a higher magnesium level. Respiratory depression is a very serious side effect. It would more likely come well after the loss of deep tendon reflexes. And interestingly enough, there was a study done, and I don't have the reference for you, and I don't even know if I could find it anymore because it's really old, but there were two anesthesiologists who sort of medicated themselves with magnesium, and they were being monitored by some colleagues. They wanted to see what the effects would be and at what mag level certain things were happening. And so in terms of the progression, yes, deep tendon reflexes were lost first. They did go into respiratory rest and were intubated and ventilated by their colleagues. That happened next. Complete paralysis happened after that. Complete body paralysis. They did not go all the way to cardiac arrest and stopped before that point, but they did draw MAG levels along the way, and I don't remember all the exact numbers, but respiratory arrest was a MAG level well above 15 in these two people. Okay, think about therapeutic MAG, about 4 to 7. Okay, so if your patient is on magnesium for preterm labor and she's making urine and she has good reflexes, she's not going to quit breathing in the next 10 minutes, okay? And that's not to say that we're not going to monitor every patient carefully, and most of your unit guidelines have policies in place where you're checking these things on an hourly basis on these patients. But I think it's also good for you to think about the real physiology here and not just do things because you have a checklist for it, but think about why am I doing it and really what is my concern level for this patient. Drawing MAG levels is not considered to be a standard of care that you have to draw MAG levels at some routine time frame. It really can be based much more on your patient's symptoms. And the best way to treat an elevated MAG level, turn her MAG down or turn it off. So I see that more often in practice now. I think years ago we were more likely to draw a MAG level and kind of see what it was and then make some decisions. If our patient is symptomatic now, like loss of reflexes or her respiratory rate is decreasing, we should turn her MAG off or turn it down. We got to protect the health of the mother. So those are important things. Contraindications for MAG, myasthenia gravis is the absolute contraindication for giving magnesium sulfate. Very rare to see that. You do want to use it with caution in your impaired renal function patients, again, because it's processed by the kidneys. Now, the big reason that we give magnesium sulfate for preterm labor, and a lot of you raised your hands and said it's probably the first drug that you're likely to see given in labor and delivery. It's not because it works so great at stopping preterm labor, but because of these studies that have come out showing that there is very likely a neuroprotective effect to the developing fetus. And so the studies have shown that there is a reduction in the occurrence and the severity of cerebral palsy in patients who have received magnesium sulfate. So this is, again, what I listed for you here is actually a Vanderbilt policy. So I want you to make sure that I'm throwing this out as something I just thought you might find interesting. Don't take it as this is coming out of ACOG or SMFM. But this is what one of our best practice policies. Any of our patients that have confirmed preterm PROM, preterm labor with intact membranes, and any other patients in which delivery is planned within 24 hours for fetal indications such as IUGR, if we have the time and can buy the time to do it, we will give a 6-gram bolus of mag sulfate and then 2 grams an hour for 12 hours. So that's our policy for the neuroprotective effect. If they are on that and still contracting regularly, we will add Indocin is our general policy. So when you think about what works the best, probably Indocin. If you go, I don't know how many of you read Up to Date or kind of use some of those references for a good compilation of the literature. Indocin gets more kudos, I would say, for doing a pretty good job of treating preterm labor, but it has those fairly significant effects that can happen to the fetus. So if MAG has the benefit of neuroprotection and it stops her contractions, then that's all that likely we're going to give. If we're giving the MAG for neuroprotection, she's still contracting with it, our policy is generally to add Indocin next. Okay, so a little bit about steroids, and again, coming from the perspective from a nursing care perspective, what should you know and what should you be able to tell your patients about why they're getting this enormous shot that doesn't feel very good? Steroids are the best thing we have in terms of promoting a better outcome for a baby that's going to be born preterm. It is by far the best thing in our arsenal right now. And so lots of studies out there that have shown it lowers the severity, the frequency, or both of respiratory distress syndrome. It lowers the frequency and severity of intracranial hemorrhage, especially in the babies in the 24 to 28 week group. Lowers the severity and frequency of necrotizing enterocolitis, and also lowers the death rate for preterm babies. So we want these babies to have the benefit of getting steroids. Is that kind of fading? It's weird. Okay, I don't know why. Okay, now is it back? Okay. So ACOG Bulletin from January of 2016, again, what I put in blue there is kind of the new wording. This is what's different from the old ACOG Bulletin. They've always said 24 to 34, but now they're saying you may consider steroids beginning at 23 weeks for women who are at risk of delivery within 7 days. And so again, does that mean sometimes we overtreat? Yes. Sometimes we give steroids and that woman goes home and comes back at 40 weeks. The good thing, I think, is that we give typically 1 round of steroids compared to back in my early days of nursing when we did send patients home. Maybe they were treated with MAG, they stayed in the hospital for a week or two, they didn't deliver, they go home, they come back every week to their doctor's office and got another round of steroids. We had the home health nurse going out to give dose number 2, they're coming to the office to get dose number 1, and I remember specifically working with one of our MFMs and taking care of this patient who got 7 rounds of steroids. And we thought that was like the greatest. Like, she's 33 weeks, she's still pregnant. Another shot of betamethasone, her baby's just going to be, great. And of course, we've learned that too many steroids cannot be beneficial and actually potentially could be harmful. So we do want to give 1 round, 2 doses of betamethasone, 4 doses of dexamethasone. There's really no difference in outcomes between babies that get one drug or the other. The benefit for the mother is that she gets 2 shots versus 4. Dexamethasone has a shorter half-life, but the ultimate benefits are there for baby. And then repeat the dose. Again, this is also in the new ACOG bulletin, but repeat the dose if they still remain at risk for delivery at less than 34 weeks, and it's been at least a week since they had it. So 1 kind of rescue is considered okay. All right, so this is from New England Journal of Medicine. This is also kind of hot off the press, being published in February of 2016, so you may not have seen this yet, that actually is looking at benefits to the late preterm baby. So now looking at giving steroids potentially to those between 34 and 36 weeks, where we traditionally have not done that. But they actually found in women that were at risk for late preterm delivery, it decreased the need for respiratory support during the first 72 hours after birth. So that may be something else that you'll see coming down the pike in terms of the way you take care of your patients. We may be giving steroids to patients further along than 34 weeks. And I thought that was very, very interesting to hear. Okay, are we tight on time? Okay. Okay, I'm going to finish. I know y'all are starving. I'm sorry. Let me just talk briefly about fetal monitoring. This is another big thing that we do in labor and delivery. And it's very important, although there's not any different nomenclature that you're going to use for your preterm patient, you need to think about the fact that this baby is not going to tolerate labor as well as a term baby would. And some of the studies that I've listed here that you can see, and I won't read these out loud to you, this is nothing new. Okay, this first study that showed that babies with lower APGAR scores and abnormal fetal heart rate patterns in labor had a higher chance of developing respiratory distress syndrome, that's from 1972. Okay, so we need to be very, very careful in the monitoring of these preterm babies once they are laboring and are going to deliver. That we are very alert for changes in fetal heart rate, that once you start to see variability diminishing, once you see the development of significant decelerations, you need to be quicker to notify your provider. If you've got a provider at home because it's nighttime and you need to be quicker to call them in because that baby is going to decompensate more rapidly. And if we have a baby with low APGARs and gases that are consistent with metabolic acidemia, that preterm baby is going to have a worse outcome in the nursery than its counterpart, same gestational age, that was born with good APGARs and a normal gas. So really, really think about the careful monitoring of the fetal heart rate and intervening more quickly and getting that provider there more quickly to try to get that baby delivered before there is any chance of hypoxia. As you know, average baseline rate's a little bit higher in the preterm baby. That has to do with nervous system maturity. So we would still should be in the 110 to 160 range, but tends to run a little on that higher end. Accelerations are of lower amplitude, so we know that the whole 10 by 10 thing for babies that are less than 32 weeks. I think it's important for you to know that the 15 by 15 accel that we use for reassurance in the older babies is based on excellent research. The 10 by 10 accel is based on one study, and it's really sort of like, well, it's just sort of really a relaxation of the other criteria. It's not as evidence-based as you might think it is. Variability somewhat less in the preterm baby, especially the 24 to 26 week babies. Again, nervous system maturity, that parasympathetic branch is maturing more slowly throughout gestation, really produces variability. And variable D cells are more common at 20 to 30 weeks, even without contractions. Variable D cells in the preterm baby can increase their risk of intracranial hemorrhage if they are significant variable deceleration. So again, you might want to work a little bit harder on trying to relieve those D cells or notifying the provider about them more rapidly. And they definitely can cause the baby to deteriorate more quickly. So I just thought I'd show you, this is a 29-weeker we had in our unit recently, and I just wanted to point out those very mild little variables that you see there, very, very common. This patient was not laboring. She was a PROM patient, just having her daily monitor strip done, and you can just see those very, very mild little variables there, not indicative of any kind of problem in that particular baby. Intrapartum, those of you that are in labor and delivery, think about the fact that the progression from normal to problematic is going to be more rapid in your preterm baby. Tachycardia is more common. There's no increased rate of late decels in the preterm fetus compared to the term, although you might anecdotally feel that way because a lot of conditions that are more likely to cause lates, like preeclampsia, a lot of those babies are also preterm because we're delivering them early. So it's not really the prematurity, it's more the condition, okay? So here's just another patient we had recently that was not quite 28 weeks, presumed choreo, and you can see there the heart rate of about 170 with minimal to absent variability. So really pay close attention. I kind of think about, these little preemie babies they're fragile when they get in the NICU. You can look at them, you see them in the NICU, they're fragile. They're fragile inside the mother too. And they're not going to tolerate the labor process the same way that your term baby is going to. So monitor them carefully and be alert for changes very carefully. I'll skip that and I'll stop and say thank you very much for your attention. I'm sorry we went a little long.